All right. This is the review. I hope my voice holds out. This is the review for exam one. That's how it'll be listed, and I will post it for you. So basically, what I do for those who are unfamiliar with how I approach it, basically, I look at the exam as I'm talking to you. It's principally skin and bones. There's a handful, maybe 5 to 10 questions tops on the chapter one material, sort of the basic anatomical structure. There are a total of 60 questions that are multiple choice, true, false, matching style, what everybody calls objective. And of course, it's choose the best answer. We start with the skin, layout wise, then bones, and then end up with those last handful of questions on chapter one. So the strata of the skin. And I spent a lot of time with it. I'm a nut for epithelial tissues of all different types. I told you that. So the stratum spinosum and the stratum granule, all those key features. Basalis, it makes this stuff. So we know basically it's a germinative layer. It's a single layer. It's columnar, cuboidal. And the cells begin to move away from the blood supply, they increase in number and they begin to become distorted. So we start with the spinosum. Again, those are the ones that sort of like little spiny points. Now, whether that's an artifact from processing and staining and looking under the microscope, or it's a real change, I don't know. So you begin to see those projections that appear to be going on. They adhere to each other, okay, distinctly, and whether it's that. So effectively, it's I think it's more of an illusion when you see that pointy appearance. I don't think that those are things that are projecting from the cell so much as it's just the cells holding on to one another at desmosomes and the changes in the slide. And yes, it's picking up more pigment and things like that. The granulosum is where you first start to see something unusual in the cell. The nucleus flattening, the cell flattening. You see keratohyalin granules inside of it. And that's really the precursor step to the cell dying and then eventually becoming a bag of keratin, for lack of a better way to describe it. And again, once you get farther away from the base, now you in thicker skin like palms and soles, you get that lucidum. And the consensus for most of us is it's just a layer that does not stain. It's nothing that disappears. It's a layer that just does not stain. But it's defined by thick skins, principally palms and soles, lower back. And by this time, the pigment has become somewhat incorporated. Pigment is produced by melanosomes, and rather than melanocytes, and the melanosomes are in the melanocytes. But more importantly, we all basically have the same range of cells. So people of color uh, don't have any necessarily more melanocytes; they just have more active melanocytes. It's really it's sort of a genetic predisposition. The range based on ethnicity is probably between eh, as little as many as 25% to as few as maybe 10% of the cells in the epidermal layer. It's the best you can describe it. And the hornium or corneum, rather, or the stratum corneum or the so called horny layer is just that. Cells that have died, they're flattened, the nuclei are gone. There's a relatively large number of them. And basically that's and they're the protective layer. And depending on the author, 20 to 40 of those layers. There's surely at least 40 layers of lining cells that are there. The keratin is a structural protein, and the, and even though it's not necessarily it's a softer keratin than what we find in harder nails, it is structurally very similar to those proteins, but not identical certainly. And then we look at the layers underneath it. You have a two-layered dermis, and basically it starts with what's always underlying epithelial tissue, loose areolar connective tissue, and what's above it, and I beg your pardon, what's deep to it or below it is dense irregular connective tissue. They're not equal by any stretch. It's about 20 to 80% superficial and then deep. So the deeper layer is certainly more dense. They're interesting because that's and really the dense layer is more it's the tensile strength, the stretch, the give, the integrity of the skin, and it's difficult to injure. That's why we don't that frequently see superficial wounds that require stitches or anything like that. That's really strong structurally integral material. Where on the other hand, that superficial layer is very interesting because that's where the blood supply, and it's based on the amount of surface area. And those series of ridges and pegs, often called Rete ridges and Rete pegs, that's capital RETE, are really where the surface area is. And the structure is such, and I love the relationship with structure and function. Not only is it surface area, but it resists that pulling and tugging that leads so easily to blisters that are there. And there are some people, again, hereditarily have a condition called pemphigus. You don't have to know that where they blister relatively easily, and there's varying genetic variations of that. So, and it's interesting. I love dermatology, and I love doing dermatology in practice, very very much. So it was really an interesting area that I felt that I was pretty good at comparatively dealing with a lot of folks' skin problems, and I had a fair amount of success. So all the structures of significance are anchored in the dermis, whether it's a hair follicle or a sweat gland or Meissner's or Pacinian corpuscles, nerve endings. All of those things are there, and they're there basically because they're held onto securely in that area that's there. And the dermis is really where everything's kind of going on, if you want to think of it that way. Again, pigment, technically speaking, is not just melatonin. It involves carotene and hemoglobin. The melanin is certainly the major contributor to that. We can see evidence of the carotene mostly in palms and soles, and we can see hemoglobin a lot contributing to the pigment, particularly in lighter skin areas, under nails, tips of fingers and toes. I like analogous structures, and so in that sense, uh, when you talk about the matrix of a nail or the matrix of the hair, that's the germinative area. It's like the stratum germinativum or the stratum basal. That's what makes those areas so terribly important. The hair shaft, which is the hair that protrudes, and the free edge of the nail are analogous. They're effectively dead tissue of hard keratin, but we can trim them and cut them without incident. That's there, so that's important. The cuticle and the luneal is another area that overlies the matrix. You can see that paler area. That's because it's the blood supply is sort of embedded and not as easily visible. And again, those are areas that you should be familiar with. The erector pili apparatus that makes your hair stand on end, goose pumps, goose flesh, whatever the hell you want to call it. Okay, and basically, if you're talking about color of hair, nails are based more or less colorless and are pigmented by hemoglobin. Hair has a variety of different kinds of melanin combinations that are there. Okay. And so it's about melanin and it's usually about air content. And as folks sometimes hereditarily, but typically as you get white or gray hair, it's not, it's an increase in air that we see within the shaft when you examine it. Hemoglobin doesn't play a contributing role. That is there. The different kinds of hairs are important. The distinction between vellus and terminal hairs are certainly important. Lanugo is that sort of it's almost like a hair-like outer layer that sheds in some babies, not as necessarily as common or distinctive. Um, that cradle cap is sort of a variation of that to a certain extent. Terminal hairs are the typical hairs that we when we go and get a haircut or we get our hair styled, whatever that is. And the vellus hairs are something that we see much more commonly in little kids and in women, perhaps more so in areas where they're just the hair is not as it's present, it's much more clear and less distinctive. That's there. The skin is a remarkable barrier, physical, biological, and chemical, and extraordinarily strong, waterproof, uh, salty, and acidic from a chemical basis, physically tough and held together. That those multiple layers of cells, still with the desmosomes holding them intact, even though they shed on a regular basis, there's just an immense amount of them that are there. And biologically, to me, it has to do with the sampling that goes on from the immune system, with those interesting Langerhans or dendritic cells that we see in the skin. Don't forget those Meissner's, uh, not the Meissner's corpuscles, rather. Um, those Merkel cells, I beg your pardon. There's other epithelial cells that sit on top of the nerve endings. That interesting one with the cancer there for Jimmy Buffett will make it more memorable for a lot of people. And biologically, also, the skin is covered in bacteria and fungi, and basically they're good guys. They compete for resources with potentially invading bacteria. It doesn't mean they can't cause problems, because sometimes they do. And depending whether I don't think you covered it in micro, with any time at the end of our class, I try to devote that last week to doing some microorganisms and talking about that a little bit with topics that you'd be interested in talking about. So again, temperature control, basically, shivering is muscles, but temperature control, and that's really not the skin so much as generating heat by skeletal muscle activity. Internal temperature control, I mean external temperature control rather, has to do with perspiration, which evaporates, and it's a cooling mechanism. So it's very, very useful, and it's interesting from a foodie perspective. That's why we see in cultures where there's a lot of temperature, Mediterranean, African, uh, cultures in equatorial areas where it's so hot, the food tends to be, oh, there's just the spice produces the sweating, and it's very, it really cools people. It's interesting how diet can play a role in those types of things, where we see it less in cultures that are in colder climes, comparatively speaking. Not not without, but differently. The endocrine basis of the skin is because of the activation of vitamin D, and that plays a significant role. It's all about the ultraviolet light and its impact on the melanocytes and the ability for additional pigmentation to protect the DNA. We went through chapter and verse. 3 different cancers, the basal cell, which is the most common and certainly related to those factors with regard to ultraviolet light and DNA, but the least problematic, because you just have to excise it. The squamous cell, also in exposed areas, does require what I call aftercare, which means radiation or chemo or some type of more advanced treatment. And certainly the worst one is the malignant melanoma, or we just call it a melanoma. It's based on its depth. The depth can be measured, but very often on a biopsy, we look at the levels, because if it gets once it gets down to the deep dermis or the hypodermis, the fatty layer underneath it, oh, bad prognosis. Don't forget anything with the rule of nines. I'm not going to go over that, but there's a question about that and the difference between partial and full thickness burns. Partial, by definition, are first and second degree, and third degree are full thickness burns, and obviously there's significant problems with them. The threats with burns with regard to fluid and heat loss is certainly, I mean, bigger part with fluid and electrolyte loss and the potential of infection are extraordinarily immediate threats, and they're like 1 and 1A. There's really not a big distinction between them. It just depends on where the risk factors are, because they both have to be addressed. Again, burns are thermal injuries. They're not, so they can be hot or cold, electrical, chemical, radiation based, whatever. Understand that when we see hair growth in skin is normal in nearly all areas. So the presence of hair growth is not a significant change. Interestingly, the absence of hair growth where hair used to be is much more of a circulatory change. Okay. And basically that's, and know what I commented on the burn center criteria. So that covers more or less the skin part of the program. The next, I'm going to take a voice break and have a sip of coffee. It's early in the morning. It's 7:42. So I get started early, if you're wondering, and we go on to bone. Okay. So we're going to look at the bone thing. I'm basically having to do one little thing, and I'll get there in a second. Don't rush me. I know what I'm doing. Okay. So when we look at bone and cartilage, there are some, obviously the cells basically come from the same roughly precursor line. So what do we see as the major characteristic? And again, I think it's more uh, more of just an appearance microscopically having to do with staining, and those are, of course, the lacunae. So what the lacunae are what appear to be enclosures around the cells. Again, I just don't think that's an area where the combination of ground substance and fibers stains as uniformly, and it appears to be a clear zone, and it's undergone a different degree, I think, of maturation, but it's there, and we talk about that. So that's the big finding that we see relating both bone and cartilage. Again, the predominant fiber in bone is collagen. We really do not see elastic tissue in bone. Reticular fibers, technically speaking, there is reticular connective tissue, but that's more within the blood forming area of the marrow. So it's not really a constituent in the structural makeup of either cancellous or cortical bone, if you want to be technical about that. And I frankly think that's important. We're looking at cortical bone, it's certainly all collagen. Maybe you could make the argument on cancellous or spongy bone that there's some reticular fibers in there, but as in addition to the collagen, I don't think so. Again, cartilage is very, very distinctive. It has that sort of an opaque or frosted glass appearance, very distinctive. And certainly when it comes to bone, it's all about hyaline cartilage. Again, the other cartilages are really, we see them as connectors, but we don't necessarily see them as part of bone. It's all about the hyaline cartilage because that's where the bone comes from. Flat bone's like a sandwich. It forms what's called intramembranous bone. It forms in a membrane. And you can see that series of slides that's on the PowerPoint. And what happens is they start to condense in membranous tissue, and all of a sudden we begin to see first cancellous bone, and then eventually the flat bones form with a surround of cortical bone. So it's like a sandwich of cortical bone with cancellous in the middle of it. The big area when we have bone that is damaged has to do with the periosteum. That's why it's so critical when it's in surgery where we want bone to be repaired, that we preserve periosteum, because other than the fact that it's very, very painful if it's destroyed and irritated by a lot of dissection or a lot of surgical intervention, it's really important because that's where the osteoblast and the osteo it really comes from, the osteoblast, the osteoclasts. A great deal of them are located on that sort of barrier between along the edge of the periosteum where it abuts the bone, so to speak. And so when we look at compact or cortical bone, the osteon is what predominates. There really isn't a predominant structure other than that trabecular pattern of plates and sheets and little spikes of bone in the cancellous bone. That's more random and based on weight bearing patterns and usage patterns. But the cortical bone is certainly that osteon, that very distinctive series of layers called lamellae, where you can see the central canal, and they have that sort of a ring-like structure that looks slightly analogous to what a tree ring might look like. I think that's the best way to describe it. The crystals are, remember the fancy word hydroxyapatite, mostly calcium phosphate, pretty much, and maybe there's a touch of magnesium, but the principal ones are the calcium phosphate, the communicating lines. Remember, there's the central canals, the blood supply going along the long axis, sort of up and down. Going tangentially to that, toward the center of the bone, or from the layers toward the central canal, are those Volkmann's canals. Okay. And then the canaliculi, those little canals, are really communications between the individual osteocytes. And they really are just areas where those sort of tentacle like projections of the cells have become entrapped in the now calcified and becoming bone portion of matrix and fibrous material that are there. Okay. Enchondral or endochondral bone means bone coming from cartilage, and the vast majority, other than skulls and clavicles, effectively almost all, very much all of the extremity bones are from that. So we look at those types of things. And again, in growing bone, we see a clear zone that's reflective of a growth plate. Okay. And it, again, it's an important tool that we use as to where fractures occur because it's a structural weak point, as we went into. It is also an area where there's a where where it helps, at least forensically, to identify about the age of the person that the bone came from. That's there. So it's a very, very useful tool that's there. And so it looks clear. Typically, it's maybe a little wavy. It's not harshly irregular. And that's the way you look on an x-ray. You can distinctly look and determine whether this is a fracture or whether it's a growth plate. In the old days, we used to see this, and because sometimes they were appearing in a certain area, and they used to call it the intern's fracture. So you put up an x-ray to try to trick a student or a first-year doctor and say, "Oh my God, is this fractured or not?" "Well, yes, it is." He goes, "No, that's the intern's fracture." So we used to do that particularly with the talus, which is the one of the bones in the ankle assembly. That's there. So what's a fracture? An interruption in the integrity or the continuity of the bone. That's all. It can be bone that's been lopped off or pulled away. It can be a tiny break in the cortex. It can be a tiny imperfection in the cancellous bone. It may or may not show initially on x-rays. Very often it shows at times of healing. It could be grossly distorted. And that's really the best way to look at it. It doesn't, the degree of damage, the degree of pain, the degree of bleeding, whether or not it's in pieces, all of those things, okay, are significant, but certainly don't define the fracture. So we look at the inflammatory response, which occurs right away in about 3 days. And after that, we get that the blood begins to organize, and immediately it forms this sort of callus. And the callus, and this is just a firming up of the hematoma, and we start to lace it with little bits of cartilage. And eventually, if we begin to go toward a bony callus and eventually toward union, which is absolute bone healing. Again, the different kinds of fractures, because I spend some time, if it's in more, if it's in, again, if it's in 3 fragments or more, comminuted. Compound has nothing to do with the number of fracture fragments. Compound indicates it's an open fracture where bone has been exposed to the air. It doesn't necessarily mean the bone is protruding. It means that a defect has been created in the overlying skin and tissue that has allowed the bone, if not permanently, but or if not visibly rather, but at some juncture been exposed to the air. And because at that point it's now presumed to be infected, it alters the treatment pattern. Again, some of those things, the spiraling fractures in children is certainly is a real warning sign about potential abuse. But if it happens in sport, it's not. It depends on the. That's why it's important to get a good history of these things. Green stick fractures are fractures that are seen in growing bone. We would call them an incomplete fracture in adult bone. It doesn't minimize them. The interesting with the green stick is the fact that sometimes you have to fracture it through in order to set it. But children's bones heal, brilliantly, so there's no problem with it. Don't forget about osteoporosis and all the risk factors that are involved. That's a loss of bone substance. It's not just a loss of calcium base. That's more in the line of osteomalacia or with regard to vitamin D or rickets that we discussed. It's a little bit different. Osteoporosis, you lose osteoid, the organic as well as the inorganic material of bone. And again, bones are about 2/3 inorganic. Those calcium salts are the predominant heaviness of bone, not the fibers, not the matrix, not the or so-called organic material. And bone, we all know, and I say it all the time, is a magnificent blood supply. Okay. That's all significant. We talked about those zones. Remember where that cartilage really starts to hypertrophy and then begin to calcify. That's the structural weak point within that uh, growth plate. That analysis is important. Again, remember the central canal, long axis, the Volkmann's canal, right angles to the long axis, pointing centrally. Okay. Remember that wonderful slide with the fibers going in, with the bone fibers, so to speak, the collagen patterns going in one direction, spiraling in one, and then spiraling in another direction. I think that's very fascinating. Osteoclasts are a multicellular unit of effectively white blood cells, macrophages with a ruffled border. But what they do that's interesting is those pockets of them that play such an important role are called resorption bays. Don't forget Wolff's Law that bone forms as the forces are on it. The difference between osteomalacia and rickets. And again, which is adults and which is children. The particular ways that calcium is either increased or decreased. Remember, it's all about parathyroid hormone for increasing the amount of calcium in the bloodstream. It acts directly on bone, it acts to retain it at the kidney, and it acts in concert with vitamin D to absorb it from foods and materials that you ingest. So it really plays an important aspect with regard to all of those things. So you need both parathyroid hormone and the activated vitamin D to satisfactorily increase calcium in the bloodstream. To reduce it, that's the calcitonin that puts it back into the bone. And now, lastly, we have a few questions about things like I pointed out what an emergent property is. When you get that organizational table, it's like when you go from tissues and put two or more tissues together, you have an organ, and the organ has a distinct tissues. Really, they have a limited amount of functionality, but when you put a bunch of hepatic cells in a particular formation and surround them by a capsule, a different kind of material, now you have a liver. And it provides a myriad of things. So an emergent property, which means each level of that organizational table, as you increase it, something new happens. So, I mean, you can take macromolecules, when you finally put them together into an organelle, now you get a mitochondria, now you can get energy transformations, just to give you an idea with that type of things. So that's really what it is. When we see a change as it improves level to level, we put a plasma membrane around a whole bunch of organelles. Now we got a cell, and the cell is the first thing that can survive on its own. And we have cells that do function individually, like white blood cells. Positive feedback examples, principally blood clotting and delivering a baby vaginally through the birth canal by actions of Pitocin. There's a few we haven't touched on yet in female repro. Additionally, we'll get to that down the road, but that's next term. So those are the positive feedback. By definition, everything else is negative. Okay, so all of those are important. Where some of the organs do. The spleen is even though it plays a role in it's really dual function. It plays a role in your immune system, but it also plays a role in getting rid of red blood cells that have so it's both circulatory and immunological. The stomach could certainly be digestive. A peripheral nerve would certainly be nothing more than being part of the nervous system. Okay, and then so understand where things are. Epidermis and dermis are obviously part of the integumentary system, and osteon would be in bone. So understand where those are. Okay, and also, another word that I didn't emphasize it, I've touched on it a lot. It's called colligative properties, and colligative properties. I'll give, and it's particularly of water, and it is because we're everywhere. We're nothing more than a big floating bag of water. So what is water? When we take a look, and you can Google that, the colligative properties, and I'm reading you a definition from London South Bank University. A solution consists of freezing point, boiling point, vapor pressure, osmotic pressure. These are all things that play a particular role. So what it means is that when we do something with water, and I know I probably should have touched on it before, but when we do something with water, okay, by adding material to it, so colligative properties, when we put all the things, the salts and the chemicals and the hormones and the waste products in water, it's very, very significant. It really affects osmotic pressure. And osmotic pressure is the ability to hold water in the system. That's what proteins do. They make something called a colloid, which you should have gotten from both chemistry and biochemistry and organic chemistry. Okay. When you add salt to water, and this is from a cooking perspective, when you add salt, you lower the boiling point. You also lower the freezing point. That's a colligative property. So the bottom line with that is the ability to water to effectively change a number of its properties when we add things to it are collectively referred to as colligative properties. And they are vital to understanding homeostasis. And that's why when you lose fluid and electrolyte balance, when you lose electrolytes, you alter those colligative properties and you're at risk. So when you have vomiting and diarrhea or uh, a bad burn or something like that, and it alters those values, it really plays a tremendous role. So I thought I'd emphasize that as part of this little review. And that concludes this little review that I will be delighted to send to you, and I will even send you an email indicating where I have done it. Nice chatting with you today, and see you tomorrow. As long as my voice holds out and I feel better, and I'll be in a good mood if we know who wins tonight. Goodbye.